Assalamu alaikum. I welcome you to the second lecture of facial nerve. In this lecture, we will do quick review of the facial nerve and we will discuss its lesions. Here is the facial nerve course. You can see it arises from the pontomedullary junction. It leaves the brainstem by coming out through pontomedullary junction along with the vestibulocochlear nerve. Then it travels towards the internal acoustic meatus. While coming out, it joins with the two roots, the motor and sensory root. They both unites and form facial nerve. It travels towards the internal acoustic meatus along with the vestibulocochlear nerve. Then it uh, travel within the internal acoustic meatus. Here it gives two branches, the greater petrosal nerve that go towards the pterygopalatine ganglion, that is given by the geniculate ganglion, and from this geniculate ganglion it takes a sharp turn and uh, and it enters into the facial canal. Here it gives nerve to stapedius muscle. Then within that canal it also gives cauda tympanoid nerve, which travel along the lingual nerve, and it gives as fibers to the tongue. Then it comes out of the stylomastoid foramen. Uh, when it just come out of the stylomastoid foramen, it gives a nerve that is to nerve to the digastric. Here it is given to its posterior belly of digastric. Then it gives a nerve that is to the stylohyoid muscle. Then it also gives posterior auricular branch to all the auricular muscles of the ear. Then it enters into the parotid gland, where it divides into two trunks, temporofacial and cervicofacial. The temporofacial further divides into temporal and zygomatic branches, and the cervicofacial divides into buccal, mandibular, and cervical branches. These five are the motor branches that are given to the respective muscles. Now we come to the clinical aspects of the facial nerve. Firstly, we come to the facial weakness. There are of two types. One are the peripheral or the lower motor neuron lesions that result from lesion anywhere from the facial nerve nucleus in the pons to the terminal branches of the facial nerve. And the second one is the central facial palsy, that is due to the lesion involving the supranuclear pathway before the synapse on the facial nucleus, like the corticonuclear fibers that were coming to the motor nucleus of facial nerve. Peripheral facial palsy, in this type, there is flaccid weakness of all the muscles of the facial expression on the involved side, both upper and lower face, and the paralysis is usually complete. The figure here, you can see the figure of the peripheral facial palsy. Then is the Bell's palsy. This is the most common form of lower motor neuron facial palsy, and uh, it occurrence is increased when there is elderly diabetes, in hypertensives, and there is increased incidence in women during the third trimester of pregnancy, 2 weeks preceding delivery, 1-2 weeks postpartum. Its clinical features include acute onset, Half of the cases attain maximum paralysis within 48 hours. All cases are clinically prominent by 5 days. Pain behind the ear may precede the paralysis by a day or two, impairment of the taste, then hyperacusis or distortion of sound in ipsilateral ear due to paralysis of the stapedius muscle. The paralysis in case of Bell's palsy is partial in 30% of the individuals, while it is complete in 70% of the cases. And 1% of the cases, the Bell's palsy involve both sides of the face. By this, we come to the end of the facial nerve. Thank you for your attention. Allah Hafiz.